to Clinical Practice and Outcomes stream at SNOMED CT Expo 2025. Thank you to FAST for sponsoring this stream. My name is Sonja Ulrich. I'm the Software Development Manager at SNOMED International, and I'll be your moderator for today's session. We'll address all questions at the end of the presentation. For our online audience, please use the Q&A button to submit your questions to the presenter. For those attending in person, feel free to use the microphone provided in the room when the time comes. It's now my pleasure to introduce Dr. Ismat Sulaiman from Health Informatics Center Planning Division, Ministry of Health in Malaysia, who will be presenting an approach to monitor obstetric clinical indicators using SNOMED CT encoded clinical notes. Ismat, over to you.
Thank you. Right. Start. Let's start. Okay, here you go. So I'll be presenting on behalf of the Ministry of Health, Malaysia. I'm Dr. Ismat in the Health Informatics Center at the Planning Division. Okay, so this project is actually a continuation of an old project where we actually developed a tooling, a natural language processing tool that actually identifies the clinical terms that is relevant for monitoring certain indicators extracted from the clinical notes. So unstructured text data, right? So the idea behind this was actually back in 2016, 2015 already. At that time, we don't have large language model, right? We're still exploring about natural language processing. But at the end of my session, I will share a little bit our way forward in how to incorporate this new technology called large language model, and hopefully we can utilize it. So the motivation behind this, right? The motivation is at the Health Informatics Center, and I think in many ministries or even at the hospital level, we tend to want to monitor the quality of care. And usually we have clinical indicators to do that. It's as simple as monitoring the waiting time of patients at certain places, at the clinics and the hospitals, or monitoring for complications of certain procedures, right? But to monitor that, the usual method, even though we're in 2025, I would have to say a lot of this method are still very manual, right? So conventionally, when we want to monitor a KPI, let's say next year, we're going to start to monitor this indicator, a complication of a procedure. Usually the people at the hospitals would have to collect the data monthly, daily, monthly, either in a, probably last time was in a book, but now it's more like you got Google Sheets, right? It's just a translation of that, the way of capturing the data. But someone at the center, they would have to manually submit or at least monitor that shared Google Sheet, aggregate the data from different provinces or different states, and then the report would usually come sometimes 1 year later. So whatever action you want to take is usually quite late, right? And it's basically an observation of what has happened. So with this tool, what we call MyHarmony, why we call Harmony is because we try to harmonize the different terms that we have in our clinical documentation, is where we do not need to even have a data entry again into a separate system. We take from the original source, which is usually what is documented in a discharge summary or in a operation theater report, OT reports, and all that. So whatever the doctor has documented, that is actually what we take. So we take from the original source. There's no data entry. And then we try to automate those data processing from the flow of that hospitals or clinics into the centralized system, automate the processing, detect any data cleaning that's needed. And the good thing about this is because we do this at the back end. Usually we share the data, we can decide to share the data on a weekly basis, on a monthly basis, at night when it's not really active. So whatever processing on a daily basis, it doesn't affect the operational system at the hospitals, slowing down the clinical workflow. And then we get the data in granular form. That means in individual form. We know who the patient are. We know the age is no longer in aggregated number. Usually they only collect, like for example, for month January, how many patients got a complication after a procedure, right? It's just a number. And you know, numbers can be easily manipulated. If you want it higher up, you can never check. But when you have granular data, it's not easy to actually manipulate the data anymore. You send it as is. And because we can extract this data in a timely fashion, at least the one that they decide they want to monitor weekly or monthly, they can take action much more, faster, right? So that's the motivation behind this tool. And we have this tool is actually starting 2018, 2019, and we started with cardiology, right? Cardiology. So now we want to expand it. What we've learned so far, we can apply to other clinical specialties. We approach basically the action when we want to do this project. We call it based on project, based on head of the specialties, because there will be three parties involved. Us at the Health Informatics Center, who knows about SNOMED CT, who manages this application, the IT engineers, who will be submitting the data to us, and of course the IT engineers who actually look into the system. And then the third is of course the clinicians. They are always involved in the early beginning, right? So we have now expanded it for this project for this year. Our aim is for obstetric clinical indicators. So the idea when we sell it to them is to automate their monitoring of obstetric clinical indicators from the clinical notes using MyHW or MyHarmony, basically, natural language processing platform. And these are the processes that we do. So the expected output is actually all the data or the data from the participating hospitals who send their clinical notes or discharge notes and then send it to MyHW, MyHarmony, and produce those reports monthly. So the clinicians just need to look at this, open it up, and then they will be able to see which one is actually reaching their objective, which one does not. Okay. So in a more detailed way, this is how we process the data or the data flow, right? So from the clinical text, we have to first, of course, identify where are the information are stored, whether is it in the clinical notes, in the discharge records, in certain reports. Push it into MyHarmony, and MyHarmony is equipped with SNOMED CT as well as LOINC. So MyHarmony, what it does is actually a codification engine. It will identify the terms, so basically a name entity recognition. It will identify the terms that we want in our small data set, and that data set has actually been mapped to SNOMED CT code. And if we want to show this to our clinicians so that they can understand better, is the third picture there, coded and structured data. So in there, for example, if we do this on just on the diagnosis column, then it will pick up those terms, right? For example, here it got infective diarrhea or heart failure, fast AF, right? So, and then it will codify automatically, right? And then they push it to a reporting engine, which is the Mahal Data Warehouse. If you want to see how this works even further, you can take a snapshot of that QR. There's a video actually where you can see the work back in 2019. Okay. So for obstetric care, they actually presented us at the Health Informatics Center 10 clinical indicators, right? So of course we have to discuss with them which clinical indicators are actually suitable to be analyzed using MyHarmony, and which one we think that is not really suitable for MyHarmony. Some of this data are structured, already stored in the EHR. It's just that sometimes, clinicians doesn't really understand how the data is being stored. So we usually will advise them, for example, timeliness in surgery for very urgent case of cesarean section within 30 minutes of decision time. So to me, it's just trying to identify in the EHR where are those timestamps, right? And then you can analyze. So it doesn't really require a natural language processing, um, trying to analyze the text, right? So for us, whereas if you look at the left side, the first five, these are some of the things that we can actually extract from the text, right? For example, percentage of unrecognized ureteric injury during benign gynecological surgery. So what we do is we try to find the term benign gynecological surgery, or if we don't have that in SNOMED CT, we will work with the clinicians to identify, okay, what are those surgery that you understand, and then we can populate it, and then we can ask my harmony to aggregate those numbers, right? And then if you say that, oh, okay, unrecognized ureteric injury, we will have to ask, okay, do you actually say in your document unrecognized ureteric injury, or are there type of injuries that you actually document? So we help those clinicians together and come up with a data set with the relevant clinical terms that we want to capture, and then we will codify it with SNOMED CT. Right. So these are usually our work process so that they know where they contribute and where we contribute, what is their role and what is our role. And I think this is very important because learning from the cardiology, what we did before, sometimes engaging clinicians too early, sometimes it's quite, can be very, they can feel overwhelmed. It's like SNOMED CT is like, this is so big and what do I have to learn? This is something new, right? So based on that learning experience, we now know, okay, where they should need to be involved, how deep they need to know SNOMED CT, or, only on the surface level. Because at Health Informatics Center, there are clinicians. So we do the mapping, and then we will show those mappings and then clarify with them, is this what you mean? So they do not have to actually handle the tool and trying to find those concepts, right? So the idea why we developed this method is because we want to let them know where do they play their part and where do we play in our part. So for example, the first is setting up the team. So usually it's just a general indication of saying, okay, this is what we have. Are you interested to join? If you are interested, we can share with you, and please have an endorsement. So usually in Malaysia, there will be one, each specialty, they have one head of specialty for the country, both covering the public and private sector. So they are basically representative for that fraternity. So we usually, even though there are people probably are interested, they will have to go to the head of department, head of specialty to get endorsement. Number two, once that is done, then the work began. So the clinicians need to determine what are the indicators, right? And then PIK or Health Informatics Center, that's us, we will develop the ref set and the mapping, right? And the IT people, the engineers, will start extracting the data where the data should be, like for example, discharge summary or operational notes, right? And then once that data comes in, then we will do the exploratory analysis. Basically, do they actually have this data documented, right? Are we actually capturing the right term in there? So those are the steps that we do during the exploratory data analysis. We will codify. Basically, we will use the tool to codify, but what we do now is a lot on validation. Okay, so once that happens, is step number 4. Usually step 3 and 4 is iterative, going back and forth. And then sometimes we will ask the IT team to actually identify this is not relevant, or we need more types of notes to capture this data. So the IT will identify those and give it back to us. We sometimes engage the clinicians to verify the output, whether does the trend looks similar, because sometimes specialties, they have their own clinical registries. So every 2-3 years, they will have a report and they have a certain trend that they see. So even though the numbers may not be the same, but they can verify, for example, does this trend looks right? Does the pattern looks like, does increase in certain month and low in certain month? So for example, For cardiology, we know that in certain months there is increase because of the Eid celebration. So there's a lot more people having heart attack. So those kind of trends, you know, those kind of things that only the clinicians actually know, the patterns that they see on the ground, right? And then, of course, if there are new terms that needs to be included, we do show their own notes, basically say, this is what you wrote. Do you want to add this as synonym to that SNOMED CT concept, right? So it can actually capture. So that iterative process, I think, is very important. And when that is good and done, then we push it down to the analytics component, and they can actually just monitor when they want to, or when they need to, right? So for obstetric case, actually, we are still at level 4. We're still going iteratively, and hopefully we can get to live early next year, Q1 next year. Okay, so as a summary, got 15 minutes, good. As a summary, I think why this is taking up, actually we've got a few requests now from different specialty to look into this. And I think this is the major selling point when we actually want to apply this. It is not a new, it is a new approach. I think the technology and the methodology has been there for a long time, but it's not very familiar with the clinicians. They've always been using the old way of capturing data, right? So basically, they need to be comfortable also with the change, right? How are they going to monitor these clinical indicators? And in fact, the good thing is, since because the data is rich and robust, if they have a new question, like a new clinical indicator, they do not have to collect again. They just run a new query. We develop a new reference set to make sure those terms are codified, and then run back with the old data that they've sent to us. So it's no more about collection. You know, the data collection process is totally changed. And I think that's the kind of transformation that we want to see. But, you know, sometimes change is not easy because they will start to ask, can we trust the data and all that? So those number 3, 4 steps is very important to get back to the clinicians. All right, so let me see. So our way forward is, of course, we want to enhance the technology. We now have a large language model. I think all of you during the session heard a lot about it. It's very exciting, but also can we have to be careful about it as well, right? And then, of course, improve the data quality. So like I said, when we do share back this, how they document, sometimes the clinicians doesn't understand that, you know, people can actually read back what they write. So, and of course, the new generation, they have new abbreviations every day or almost every day. So when we show them back, okay, this is what we are reusing back what you've documented, then they start to improve the way they document, right? So it's not like when we do the clinical indicators, we show it to them. There are processes that we need to improve on the reference sets, on how we capture the data, but the clinicians realize that they also need to improve the data quality, the quality of the documentation. Because if I told them, if you don't do this, you'll go back to the old way of collecting the data, just aggregated, double entry, and so forth. If you do not want to do that, do it right the first time, which is good clinical documentation, right? So I just want to explain a little bit, since we have a little more time, is what we're trying to do on enhancing the technology, right? So early this year, we were approached by another ministry in Malaysia. The ministry is called Ministry of Science, Technology and Innovation. And they usually give huge grants when it comes to creating new innovation in technology. One of the ideas that they have is they think that Malaysia should have a large language model for the health sector, specifically in the context of Malaysia. Because, as you know, LM is very dependent on the data that we feed it into, right? So the diseases that we see in Malaysia, or at least in the Southeast Asia, may not be the same as what the LMS is, you know, seeing. For example, we have a higher case of dengue, fever, malaria, whereas in the West, probably not as much. So that's why that's the motivation for us for them to approach us. So right now, we have open, it's called a request for proposal, where either industries, whether it's researchers or universities or even companies can actually give a proposal on how they want to develop this, but we have a general scope on what we require. And that requirement, basic requirement, it contains this two objectives, basically. So the first objective is develop that large language model of containing various data sets related to health in Malaysia, right? And the second objective is to build application using that LLM. So the idea is so the project is stable out for 3 years. The first 1 year is to build that LLM first, right? The second year is to build the application. We hope that after the first year or during the second year, we can make that LLM open for people so that other people can create new innovation and tools and applications using it. And the third year is where we're going to fine tune, probably look back, add more data sets or create, look back at our large language model. This is a huge thing. It's not easy because, as you know, even when we have applications trying to determine that it is aligned, it does not do or suggest something that is not there. And the validation of it is not mainstream yet. Right? The method to validate is not mainstream yet. But it's an exciting thing. I think we need to do it, learn by doing. We always been using this method and we learn by doing. So the third year is where we're going to refine tune, hopefully. So these are some of the use cases that we think we can apply. We put it as a 3 perspective or 20 minutes. So 1 more minute. 3 perspective, whether you want to build application for public use, whether you want to build applications for patient care, those are the hospitals and the clinics, or you can actually build application for health system management. And I feel that if you want to go fast and safe, improving the health system management using large language model is the fastest way. But of course, if you can build an application that targets patient care, the impact will be huge. But of course, there's a lot more detailed work on validating, making sure it's safe. So that's the work that we're doing. Hopefully, we've got some more news next year that we can share. So that's it from me. Thank you so much.
Yeah, thank you, Ismat. Very interesting presentation. I think we have like 2 more minutes for questions. Yes, please. Would you mind using the microphone?
Thank you for the presentation. I'm interested in how extensively you are going to analyze the documents for the SNOMED concepts that you have selected in your set of interests.
So when we started with the cardiology, we've learned that we're not going to use all the SNOMED CT terms. So we actually developed the reference set based on the requirement of the indicators. So sometimes for cardiology, I remember we only use up to 6,000 concepts. Whereas for obstetric, it's much smaller because now it's just looking at, the clinical indicators, but then there might be related disorders or procedures that's outside that they might need to add in. So it's progressive. I think it depends on what they want. So it helps in terms of one, in managing abbreviations. Like for example, I mean, my clinical background is both cardiology and obstetric. Funny, isn't it? So I know an abbreviation like SVD in cardiac is called single vessel disease, but in obstetric is spontaneous vaginal delivery. So having that small reference set, you actually kind of determine the boundaries that, it doesn't mean something else. Manage it better.
I was more actually interested also in the LLM use case, for ongoing project that you described in the last slides. If that's going to cover everything that's possible in SNOMED and extract all of it from the documentation, or what the main...
Right, so let me go back. So that would be the highlighted, the bold one. So once we the LM, of course, is going to be general, as big as it can. But when we develop the second, the application, if the proposal, because we made the proposal open, these are just options basically. So they can choose what applications they want. These are suggestions from us. But even if they don't build it, then we'll probably use this LM and we build it for ourselves. How extensive it is, I guess we just have to test it. The best way, I think, for now for LLM is always, scope it so that you can create a boundary and then making sure that you can validate the work. So I don't think we want to do a big thing. Always deliver something small like this, maybe just for obstetric, and then see how it goes.
Thank you.
Okay, thank you very much. That concludes the session. To our online delegates, we're welcome to remain here for the next presentation on this stream, or you may navigate to another session via the event lobby. Thanks again, Ismat, for the great presentation, and we're on to the next one.